join Mindray Vet Solutions webinar. First, let me introduce myself, your host for today. I'm Alice Deng, PMOS Marketing from International Vet Product Sales and Marketing Department. Due to COVID-19 pandemic, we are hosting a series of webinars commencing this May to support our customers. Our last webinar on June the 4th, Dr. Sarah shared with us echocardiogram, what it shows, types, clinical cases, and practice. Third webinar by today, we will launch a series of webinars for our distributor partners and end users each quarter. Distinguished guests, ladies and gentlemen, thank you for joining us to share this informative lecture together. We know HCM is the most common cardiac disease in cats. Although it develops and progresses over time, its early signs may be subtle or non-existent. A cat that seems healthy may appear to become very ill quickly, or even die suddenly. How HCM impairs the heart's ability to function? How is HCM diagnosed? The presence of a heart murmur means heart disease. Common mistakes and latest updates. Identifying and managing feline HCM in practice are challenges for vets and ultrasonographers. We are very honored today to be joined by our distinguished speaker. Dr. Eason Yeh will share with us his experience and ideas for the above. We warmly welcome your questions during the lecture. You can type in the chat window. We will arrange Q&A section later. The last part will be the voting section. This webinar will focus on HCM, how to avoid mistakes, and latest updates. We hope to award our customers who enjoy this informative lecture and benefit from what you hear. Now, I'll be very pleased to introduce our distinguished speaker, Dr. Eason Yeh, DVM, National Taiwan University, CSAVP, Cardiology, ESAVS, University of Luxembourg, founder and director of Sonography Vet Ultrasound Consultancy, Hong Kong, consultant for big cardiac vet tele-electrocardiography. Over 10 years experience as an ultrasonographer, performing more than 200 echocardiograms and abdominal ultrasound per month. Let's warmly welcome Dr. Eason Yeh to give us the lecture.
Hi, good evening, everyone. Sorry, there's always some problem here. Okay. I think you can hear me. Okay. Good evening, everyone. I want to thank you all for attending this webinar. I'm very glad to have this opportunity to share my experience and knowledge about feline HCM. I also want to thank Mindray company to organize such a nice online course series so we can discuss interesting topics and learn from each other. Okay, as we all know that feline cardiomyopathy is always very challenging to diagnose and manage. So today I'm going to tell you some common mistakes we often make and how to avoid them. Also, I will provide some latest updates to this year, 2020, to renew your knowledge on feline HCM. And you can see this cat is my cat. His name is Martin. He will be with us these 2 hours. First of all, I would like to briefly introduce myself. My name is Eason. I'm from Taiwan. I got my DBN degree from National Taiwan University 10 years ago. And later I developed a key interest in cardiology. So I spent 2 years to finish my cardiac certification program and got the CSAVP from University of Luxembourg. I'm currently working in Hong Kong with my own company, Easonography, providing mobile cardiac and abdominal ultrasound service to over 80 animal clinics in Hong Kong. I scan over 200 cases per month. I also provide distant interpretation service of ECG cases in the clinics in Taiwan, Hong Kong, and mainland China. Okay, so for this talk, before we start, I would like to give you an overview of this talk. So first, I'm gonna give you a brief introduction of feline HCM. Second, I'm gonna talk about some traps when we examine a cat, including physical exam, radiograph, and blood works. Thirdly, I'm gonna go through some common mistakes we may make when we do an echo on the cats. There are a couple of things you should know before you scan, otherwise you will easily make misdiagnosis. And at the end of this talk, I would like to talk about the new staging system and the treatment strategies recommended by the ACVIN consensus guideline this year, just published a few months ago. So I think tonight you will get the brand new knowledge of the feline HCM. Okay, during my talk, I have prepared some questions for you. There will be a pop-up window for you to vote. So please choose your answer and let me know what's your thought. The answer time will be 30 seconds. So if you see a question, please choose your answer. So now let me try the first question. Okay, how much chance do you think an apparently healthy cat can have HCM? Okay, please choose your answer. It's 5%, 10%, 15%, 30%, or 50%. If it's a healthy cat, it looks like nothing, no clinical signs. Okay, nice. I think I see C and D is the most of you think, 15% or 30%. Okay. Okay, Alice, please close the window. Okay. The answer is 14.7%. So it's, C is roughly 15%. So what does it mean? Basically, every 6 cats present to your clinic, So probably for vaccination, for skin issues, for GI disease, there might be one of them actually has HCN, but no one aware of it. Even you, even the owner, because there's no clinical signs. So it's quite high, the prevalence, and the actual prevalence can be even higher because many cats don't go clinic until they become heart failure. So there might be more and more cats we are underdiagnosed. So HCM is the most common cardiac disease in cats, according to this research done by Ohio State. You can see the HCM is extremely much more common compared to other feline cardiomyopathies. So although the number may be different in amongst different research groups, HCM is always the number one differential diagnosis when we are talking about feline cardiomyopathy. So in this study is 91%. Some studies say 70, 80. So it's always the most common cardiac disease. Okay. And the underlying cause of HCM is not yet clearly understood. But it's quite clear the disease is genetically related and is inheritable, especially in some breeds. So you might see Maine Coon and Ragdoll are very common breeds predisposing to the HCM. There are already some specific gene mutations being identified in these breeds. And in Hong Kong, where I'm currently working at, the British Shorthair, BSH, is extremely common breed to be diagnosed as HCM. I would say almost 90% BSH in Hong Kong has HCM. So they are almost equal to HCM, BSH. Yeah, so very high prevalence. And other breeds such as American Shorthair and Persian are also predisposing breeds. But actually, any breeds like BSH, any breeds can suffer from this disease. HCM can be found in almost any age of cats. So most commonly diagnosed at 2 to 6 years old, but it can be 2 to 6 years old is quite young, so it's not really a geriatric disease. And it can also be quite young, like the youngest patient reported to be 4 months old. So personally, I also have some experience to diagnose some cats with HCM and already heart failure with only 1 year age. So don't forget this differential diagnosis in kitten. They are not only congenital disease, but also HCM can be happen. Okay, male cats are more common compared to the female cats and tend to onset earlier. Yeah, but the disease process is the same with the female cats. So typically you will see the heart like this. So usually you will see a thickened left ventricular wall, which can be in interventricular septum, or can be left ventricular free wall, or can be both. So the left ventricular chamber can remain normal size or becomes smaller due to thickened myocardial wall. Okay. The left atrial size also can be normal in early stage, but later they can become enlarged, secondary to the small left ventricular chamber and the diastolic dysfunction. Okay, so today when we are going to diagnose HCM, we have some tools to approach it. Okay, such as physical exam, radiograph, blood work, and echocardiogram. So after we diagnose, we are going to treat our patient with medical therapies. However, many vets have misunderstandings with this disease and the medications. So we have to remember that cats are not small dogs. So if we try to use our common sense in canine heart disease to diagnose feline FCN, we will easily go wrong. So next up, I want to talk about some common mistakes in our daily practice and how to avoid it. Okay, first, physical exam. So when we talking about cardiac disease, we usually think about heart murmur. If you hear a heart murmur from the cat, does it mean he has cardiac disease? Or if you don't hear a heart murmur from the cat, does it mean he doesn't have cardiac disease? Okay, let's take a look of this research. This article was published in 2009. They collected 103 privately owned, apparently healthy cats. Among these cats, 16 of them have heart murmur on physical exam, and only 5 of them are confirmed as cardiomyopathy. So if you want to predict cardiomyopathy with heart murmur, the sensitivity is quite low, with only 31%, and the specificity is higher, but still not so accurate. Another study published in 2003 also showed among the cardiomyopathy cats, only 55.7% have heart murmur, which means heart murmur is not so reliable to predict cardiomyopathy in cats. And we may have been underdiagnosing cardiac disease in cats, as we usually assume they are normal when we didn't hear any heart murmur. Then we assume the cat is normal. But it may underdiagnose their cardiac disease. So you may ask, why healthy cats can have heart murmur if he's healthy? Okay. We have to know the heart murmur, the underlying cause of heart murmur in cats are 2. So sorry, there's some mistake I'm changing here. Okay. I missed one slide. Okay, there are 2 reasons for the heart murmur in cats. So one is systolic anterior motion, SAM, of the mitral valve. And the one is dynamic right ventricular outflow tract obstruction, which we call ductal vatal, because here's a DR. We can call it ductal vatal. Systolic anterior motion of mitral valve often associated with HCN, and the ductal vatal usually physiological and can happen in healthy cats. So what is the SAM? The pathophysiology is shown by this graph. Here is the left atrium, left ventricle, and the aorta. So the blood is going to flow from the left ventricle through this route to the aorta, and we call this route left ventricular outflow tract. So if the cat has a thickened interventricular septum, so like this one in the right side, so the outflow tract will become a bit narrowed. In the early systole, the flow remains smooth because the outflow tract is still wide enough. It's not so narrow. But when it comes to the later systolic phase, the thickened septum will make the outflow tract very narrow, then increase the flow velocity. A high velocity flow here can suck the mitral valve leaflet into the outflow tract. It's called Venturi effect. So when it suck the anterior leaflet into the outflow tract, it causes even more obstruction here. So now the outflow tract is very narrowed, and here is become obstructed. So here it produces a turbulence. Then it produces an audible murmur. And in addition, as the mitral valve moves into the outflow tract, so the mitral annulus is no more closed. It's no longer closed. So it will also cause secondary mitral regurgitation, which again produces a heart murmur. So you will see like this. This is early systole phase. The mitral valve is just closed. You see the outflow tract is still wide enough, but here is the bulge of the septum. So later, the mitral valve is sucked into the outflow tract. So here become obstructed, and it produces a turbulence here. And later, the mitral valve even goes into more into the outflow tract. So the mitral annulus is no longer closed. Then it produces another turbulence here, which is mitral regurgitation. So typically, it's a V-shaped turbulence, true turbulence here. This is called SAM, systolic anterior motion of mitral valve. Then you will hear a murmur with your stethoscope. So if you see the video, it's like this. Okay, this is the first reason why the cat has that murmur. And the second reason they can have a murmur is the ductal voto, which can happen in healthy cats. So what is ductal voto? Let's take a look. In figure A, you can see here is the right atrium. Here's the pulmonary valve. So the blood flow is go from the right atrium to the right ventricle and into the pulmonary valve, pulmonary artery. So here we call it right ventricular outflow tract. Okay. And in some cats, especially when the heart rate is high, the right ventricular outflow tract may somehow become too narrow, like this one, like the figure B. So you see here, the outflow tract is quite narrow. So it makes an obstruction here. So producing a turbulence, like figure C. So this phenomenon is called ductal voto, dynamic right outflow tract obstruction, because at the early stage is not obstructed, but in the later stage it become obstruction. So it's called dynamic right outflow tract obstruction. This phenomenon can happen in healthy cats and produce an audible murmur. So this is why sometimes we hear a heart murmur from the cat, but we cannot find any evidence of cardiomyopathy on the echocardiogram because they are actually healthy cats, no cardiac disease, but they can have heart murmur with high heart rate if the heart rate is high. And many vets have told me, I got a cat with grade 2 heart murmur 2 weeks ago, but now murmur becomes grade 4. So I think it is getting worse very quickly. So I need an emergency echocardiogram. Do things right? Is the murmur intensity truly reflecting the disease severity? Okay, let's take a look here. Here is the echo measurement of the ductal voto. The velocity is directly proportional to the murmur intensity. So means that higher the velocity is, the murmur is getting louder. So on the left side, the velocity is 3 meters per second. And the right side is around, I think, 1.6 meters per second. So it looks like the cat on the left side is more severe than the right side, right? But however, this is actually the same cat in the same echo exam in the same day. So why? What makes the difference? It's the heart rate. Its heart rate makes the difference. When the heart rate is high, for example, the cat is very nervous, the velocity of the sand and ductal voltage will go higher and the murmur becomes louder. So like on the left side, the heart rate is over 200, then the velocity will be very high and producing a louder murmur. If the heart rate decrease, like on the right side, decrease under 180, then the murmur becomes softer or even disappear. So feline heart murmur is usually dynamic. You can have a cat with grade 3 heart murmur, but 5 minutes later, the murmur disappear because the cat calm down and the heart rate is not so high, then the murmur is gone. So don't blame your colleague if you hear a murmur, but he cannot hear because it's the cat fooling you. It's the heart rate. It's not really the disease severity changes. And furthermore, the most crazy thing is if you cannot, if the cat doesn't have heart murmur, you can even make one for him. So iatrogenic heart murmur, is that possible? Yes. This paper is just recently published. It's, I think 3 months ago, so in March 2020. So they found that ductal voltage can sometimes be iatrogenic if you press the chest wall too hard with your stethoscope or with your ultrasound probe. So on the left side, you can see this cat. The blood flow here is pure blue, so its laminar flow is quite normal laminar flow. So it's not a turbulent. So there's no murmur here from this cat. However, when we apply more pressure, when we press the chest wall more harder, the heart becomes like this. So it becomes like the right picture. You can see the turbulence here. You're actually pressing the right ventricular wall into the right ventricle and make it more narrow and produce the turbulence here. So you actually produce the ductal voltage. It's not the cat, it's you produce it. So sometimes if we are trying so hard to listen the heart sound, we press very hard, then we will press very hard with our stethoscope, then maybe you are actually producing a heart murmur by yourself, not the cat. Okay, so you can see the heart murmur is quite unreliable if you want to use it to predict cardiac disease. So what is better? What is the better indicator? Here's the answer. Here you can see that there are 3 groups of cats. So here's the normal cats, subclinical heart disease or heart failure cats. And you can see the green bar is arrhythmia and the purple bar is gallops. So gallop and arrhythmia increase with the disease progression. With the more severe the cardiac disease is, more gallop, heart sound, and arrhythmia you can hear. For the normal cats, there is also some arrhythmia in the normal cats, but they are actually sinus arrhythmia. So this is not related to the cardiac disease. For the heart failure group, the arrhythmia is usually ventricular arrhythmia, such as BPC, or some of them have atrial fibrillation. It's more pathological arrhythmia. So gallops and arrhythmia predict the cardiomyopathy better. And if you have a cat presenting for respiratory disease with respiratory rate over 80 per minute, if he had gallop heart sound, it has low body temperature below 37.5 Celsius and the heart rate over 200 per minute, it will be more likely this cat has congestive heart failure. So this is some clues you can get from your physical exam, but not the heart murmur. Okay. And next, what about radiograph? Should we take an X-ray? Yes. Why? X-ray is the gold standard for diagnosing cardiogenic pulmonary edema. And we can evaluate cardiac size, evaluate pulmonary vessels, and rule out respiratory disease from the X-ray. So we should take X-ray every time when we try to diagnose cardiac disease. And we should take 3-view X-rays. So regarding the radiograph, the most common mistake is like this. Do you know what's the problem with this picture? Most of the vets prefer to take a radiograph of the whole body. Means the entire cat is included into a single view. So they are trying to see all thoracic organs and abdominal organs in the same time. However, the algorithm of the chest and the abdomen are completely different. So actually you cannot see both of them very clearly. And if you are trying to evaluate the chest with the picture, with the picture like this, your focus point is actually here. So it's not focused on the chest. You are actually focused on somewhere around the liver. So you are actually taking a photo like this. So this is your chest. That is the cat's chest, and this is the liver. Okay, so if the man here is your good friend, it might be okay. But if you are taking photo for your girlfriend or your wife like this, I'm afraid you will be killed very soon. So the focus is very important. So next time, please put your patient's heart in the center of the view. Focus it. And cut out all other things caudal to the rib cage. If you really want to evaluate, if you really want to evaluate abdominal organs, please take another X-ray with proper setting for abdomen. So chest is the chest, abdomen is the abdomen. They should be in the 2 films. Okay, if the patient has severe cardiac disease, we will expect to see cardiomegaly and left auricular enlargement. But how do we know the heart is enlarged? We can also use vertebral heart score, VHS, similar to what we do in dogs. You can do it on lateral view, which in normal cats is below 8.2, or you can also do it on VD view, like this on the right side, and which the normal range will be under 8.9. Most of the vets, including me, we do lateral view usually. So from this study, it shows that if a cat presented for respiratory disease distress, and the VHS is under 8.0, then the respiratory sign is very unlikely to be caused by heart failure. If the VHS is over 9.3, then it's very likely he has congestive heart failure. So it will be equivocal if the number is between 8.0 to 9.3. You will need an echocardiogram for further investigation. But you can roughly use 8.0 and 9.3 to get some result if there is severe heart failure or it's not. However, as you can see, the VHS is not always reflecting the left atrial size because left atrium is like here, but the VHS line is not across the left atrium. So is there a better way to evaluate left atrial size? Yes, there is another study recommends the LA VHS. So you can draw the long axis line in the same way with traditional VHS and draw another line like this, line B, perpendicular to the line A and to the caudal contour of the left atrium, just dorsal to the border of the caudal vena cava. Yeah. So compare the line B with fourth thoracic vertebra. It should not over 1.3 times of the fourth thoracic vertebra. So you compare this B line to the fourth thoracic vertebra. It should not over 1.3 times. So if you are using LAVHS to predict left atrial size, it provides 95% specificity, which is quite good, but relatively low sensitivity. So why the sensitivity is so low? Here you can see this cat has a severe cardiomegaly, right? So it's quite easy to judge this cat has severe cardiac disease, right? However, if you see this cat in the right side, the heart size looks normal. So we may not expect this cat has severe cardiac disease, right? But actually both of these two cats has congestive heart failure. So there is another study. They collected 100 acute congestive heart failure cats, and they found that even with heart failure, there is 52% of the cats still have normal left atrial size on lateral view, and 47% on the VD view looks like a normal left atrial size, and there is 36% of the cats looks normal left atrial size on both view. So it's almost like 1/3 of the cats looks normal on the radiograph. So these cats will be very difficult to diagnose with radiograph. So here you should remember, in cats, normal left atrial size on X-ray does not completely rule out heart failure. Yeah, so this is sometimes the cat is fooling us. So what about blood work? Can blood work provide information of the heart? Yes, the feline NT-proBNP. NT-proBNP is a biomarker which increases when the myocardium is stretched. So both on chamber dilation or myocardial hypertrophy can increase the serum NT-proBNP. Here you can see the study shows the NT-proBNP is helpful in diagnosis of occult HCN with cutoff 100 pmol per liter. It has very high specificity. So over 100, almost all of them are occult cardiomyopathy. So you can send a blood sample to the lab and get the number of the BNP, which they call cardiopathic proBNP. It's very good for screening occult HCN. If the BNP is below 100, then a clinically significant cardiomyopathy is very unlikely. If the BNP level is over 270, it's very likely there is severe cardiac disease. However, waiting for a lab result usually takes several days. So if there is a cat in front of you, is dyspneic, is going to die, you cannot send the blood sample to the lab and wait until 2 or 3 days, right? So what can we do if there is an emergency situation? Yeah, we can use IDEX SNAP kit, so point of care BNP test. So for the SNAP kit, you have to know that the cutoff is different from the cardiopathic proBNP. So previously we talked about 100, but the SNAP kit is cut off on 150. In this study, they found the normal cat. So here is the study groups. So you can see normal, equivocal, and mild cardiomyopathy cats, they have similar number of the BNP. And when it goes to moderate to severe cardiac disease, the BNP goes very high. It's significantly increased. So we can further divide them to group A and group B. So just instead of 5 groups, we can divide it into 2 groups. So if you use SNAP-kit to predict moderate to severe cardiac disease, it gives you 88.3% sensitivity and 81.3% specificity, which is not so bad. And it's quite useful to differentiate cardiogenic or non-cardiogenic cause if a cat present for dyspnea. Like if there is a pleural effusion, the accuracy is quite good with the BMP. So you can try to use the SNAP-kit to help you diagnose if you are not able to perform the echocardiography. But we must keep in mind that every test can give you false negative or false positive result. If you got the normal BMP result with the kit, it does not rule out myocardial disease. And if you got an abnormal result, you also have to rule out renal insufficiency, as the BMP is cleared by the kidney. If the kidney function is decreased, the BMP is not cleared, then the serum BMP concentration will be increased. And hyperthyroidism and systemic hypertension may also give you false positive results. So you should rule out all of these things. Furthermore, the antibody BMP provides no clue of the cardiomyopathy type. So it cannot tell you the cat is HCM or RCM or DCM. And BMP is not designed for staging and not for you to start medications based on it. So you cannot just based on the one abnormal BMP result to prescribe some medication for them. So for definitive diagnosis, the echocardiography is still necessary. So we got the most important one, the echocardiography, which is the gold standard to diagnose cardiac disease. So on HCM, typically you will see the echocardiography look like this. So very thick ventricle is very thick interventricular septum and left ventricular free wall, and the ventricle look like this, small chamber, and if you use M mode, it will looks like this. Okay, but feline echo is actually quite challenging. So you will need a very high resolution ultrasound system. For example, this one, Mindray M9 is a very nice portable system, which I'm currently using. And also, because the feline heart is usually very small, it's much smaller than the canine heart. So you will need a high frequency phased array transducer to provide you a crystal clear image quality. Otherwise, you can see nothing, or otherwise the image will be very blurred. So echocardiography is a very nice tool that can provide you lots of numbers and lots of information of cardiac functions. However, you have to interpret them very carefully. Otherwise, you will easily fall into a trap. So let's take a look how the echo machine can cheat you. Sometimes the heart looks thick, but it's not. So here you can see it's my cat Martin. It looks quite thick on the chin, right? But sometimes it looks thick. Actually not. For example, this picture, the left ventricle looks quite thick, right? And the chamber looks small. So it looks like a typical HCM. But this study tried to demonstrate how the hydration status can affect the echocardiography result. So they collected some healthy cats and give them high dose furosemide until they lost 7 to 10% body weight, which means 7 to 10% dehydration. So this is the picture before furosemide. This is the picture after furosemide. So they found that left ventricular wall thickness is increased, and the chamber size became smaller, and even the left atrial size became smaller after furosemide. So why? This is called subdural hypertrophy. So during dehydration or hypovolemia, the volume inside the heart is decreased. So the wall looks thicker. It's just like urinary bladder. If you have less urine in the bladder shrink and looks smaller and looks thickened of the wall. So if you don't know about subdural hypertrophy, you may diagnose this cat as HCM, but it's actually not. So be careful about the hydration status, and when you echo the cat, you should check the hydration status if the cat has dehydration or not. And be careful that several diseases such as hyperthyroidism, chronic kidney disease, or GI disease, they can cause dehydration and consequent subdural hypertrophy. So you should rehydrate them and repeat the echo before you judge them as HCM. Okay, another factor affecting the measurement is the heart rate. So this study is done by the Japanese team. This study used 6 cats and performed right atrial pacing to control their heart rate. So you can see the graph here. On the left side, you can see the wall thickness is increasing and proportional to the heart rate. And on the right side, the chamber size is decreased with the heart rate. So why? It's because when the heart rate goes high, there is shorter filling time. So the left ventricle will be filled with smaller volume of blood, causing the same result with subdural hypertrophy, same as dehydration. So tachycardia may make subdural hypertrophy. Sorry, I don't know why I lost the connection. Okay, I think you can hear me. Okay, so yes, okay, nice. And okay, so tachycardia may cause subdural hypertrophy. So if the cat has severe tachyarrhythmia, like atrial fibrillation, supraventricular tachycardia, ventricular tachycardia, they will make the heart look like thickened. So it will be better to control the arrhythmia before you judge it, before you judge the cat as HCM. And hyperthyroidism also may cause sinus tachycardia, so they should be ruled out of hyperthyroidism. And if the cat is too nervous, the heart rate is too high, you may ask the owner or ask your assistant to calm them down. Or sometimes you may need to sedate the cat if the cat is really too struggle and you are not possible to do echo. You may need some sedation. So typically you will see the echocardiogram like this. So usually we do M mode like this. We divide the heart symmetrically with the line, and we measure the left ventricle, the interventricular septum and left ventricular field wall and the chamber size diastole and systole. Okay, so the number we are focused on is the diastolic wall thickness here, IVSD, and the free wall here, LVPWD. So what's the cutoff value? What's the numbers we say it's normal or abnormal? So actually, there's no magic number. There's no single number to say it's really normal or really abnormal. And some studies has published, they think that the number might be body size related. So maybe a 8 kilogram cat has a higher number than a 2 kilogram cat. But there's still no conclusion. So generally, we use this number. So if the left ventricular free wall or the interventricular septum diastole, the thickness is over 6 millimeter, then it's indicative of hypertrophy. If it's below 5 millimeter, it's considered normal. If it's between 5 to 6, it's equivocal, and you should interpret it with other things, like if whether the cat has SAM or other clinical signs. So here you can see I'm measuring this cat heart. So we said we are focused on the IVSD and LVPWD. And if it's over 6, we may say it's abnormal, it's thickened. So look at this number, it's 6.4. So we may judge is the septum is thickened, is hypertrophied, right? And for the next cat here, the number of the LVPWD is 6.3. So the free wall is thickened, but the septum is not, right? But if you look at these two pictures, you will find it's actually the same cat and at the same time, the same graph. But if I measure here, it looks like the septum is thickened. If I measure here, it looks like the free wall is thickened, but the septum is not. Why? Because when we are doing echo, sometimes the heart looks like this. So if you put a line here to measure M mode, sometimes you will find the heart is actually swing and moving. Maybe the cat is moving, maybe your hand is moving, maybe you are both moving. So it's very easy to make mistake if the heart is moving. So echocardiography needs very, very lots of experience, and it's very depend on the scanner technique. So if you are a beginner, you are trying to do feline echo, you will need more and more practice to avoid the things like this I'm showing. And it's better if you can find someone who who is quite experienced on the feline echo, and they can do a better measurement, better view, better measurement, and better interpretation for you. So it won't make a misdiagnosis. So this is the first thing we can make mistake on the echocardiography. Okay, and here is another cat. So you can see when we measure diastolic, the IVSD is 7.0 millimeter. The pre-wall looks okay, it's under 6, under 5, so we consider normal. And the IVSD is over 6. So it looks like the septum is thickened, right? And you take a look of this video. Is that a little bit weird? So you may think, what is this structure here? Another view. So previous one was short axis, now it's the long axis. And what is this structure here? Okay, not only these cats, but also the other cats has this structure here. It looks like a line across the heart, right? So actually, this is a structure called false tendon. So false tendon is a fibrous or fibromuscular band across the left ventricle. So why we call it false tendon? Because it's not connecting to the valves. Usually the normal caudate tendinate should connecting to the valves, but it's not. So this false tendon is can be seen in human or in cats or in other species. But it's actually a normal structure in cats. It's not pathological. So if you see a false tendon in the cats, it's not illness. It's actually a normal structure. Sometimes many healthy cats can have it. So like this one. So this, you can see this structure is connecting from the papillary muscle to the wall. And here, this one is connecting here to here, but the valve is here, actually here. So they are not connecting to the valve. We call it false tendon. So although false tendon is not really cause disease, but they can fool you. They can make you feel the heart, the wall looks thicker. So like this one. Here you can see that the false tendon here is more hyperechoic compared to the muscle here. So actually here is the fibrous band, is the false tendon. It's not the interventricular septum. So if you measure the thickness, you should not measure from here to here. You should avoid the false tendon. So in our previous image, I measure the septum from here to here. It makes it look like thicker. But actually I included the false tendon. This white line is the false tendon. So it's not correct. So if you measure from here to here, it will give you 7.0 millimeter, which is considered thickened. But if you measure from here to here, you avoid including the false tendon, is actually 4.3 millimeter. So it's actually not thickened. It's actually not hypertrophy. It's not a hypertrophy cardiomyopathy. It's a normal left ventricle. So echocardiography can provide you lots of information, but you have to interpret it very carefully. And sometimes it looks normal, but it's not. So for example, this one, we see the number looks normal. It's not thickened, right? It's 4.0 and 4.5 looks okay. And we avoid something, maybe this is false tendon, so we don't measure it. So looks like it's. If you look at the long axis, the heart is actually looks like this. So the septum is this shape. And if you use your MO line cut through here, it will give you 4.0 millimeter, just like we did. But actually, the hypertrophy part is here. The thickened part is here. So if you measure here, it's actually 7.2 millimeter. So this cat is actually hypertrophy, but you can miss it if you use MO and you cut through the normal portion. So feline heart can, HCM is not usually diffuse hypertrophy. So typically we see like this is symmetrical diffuse hypertrophy. This is quite easy to judge. But sometimes it can be asymmetrical. So only septum thickened or only free wall thickened. But there is also sometimes only focally thickened, only here, but not here. Not here. And sometimes only the mid portion. So not here, and not here, only focally hypertrophy. Or sometimes only apical hypertrophy, not the basal part. So you have to be careful if you miss the focal hypertrophy lesion. Okay. And what if you have a cat, it was diagnosed as HCM before, like 3 months ago, and now you did a repeat echo, then it become normal. Is it possible? So like my cat Martin, it looks like this before, but now it looks like this. Is it possible? Or they are different cats? Yes, it's actually possible. So in 2017, they had there is a study found that sometimes the thickening might be transient. It's called transient myocardial thickening. You can call it TMT in cats associated with heart failure. So it's like this. This is the first echo. So these four cats, these two cats, long axis, short axis, long axis, short axis. You can see on the left side, the heart looks quite thick. You don't even need to measure it, right? And at this time, they are heart failure. They presented with pleural effusion or pulmonary edema. But like 3 months later, they become like this. So it looks like a normal heart. It's quite thin wall and the chamber looks quite okay. And now they don't have any clinical signs. They don't have heart failure. So you can see the graph here. On the initial echo, the purple one is the TMT. On the initial echo, it looks thickened. This is the left ventricular wall thickness. It looks thickened, but later it becomes thinner. And the LAL is the left atrial size. It looks increased before, but now it's decreased. and it is within the normal limits. The dashed line is the normal limits. If the cat is the typical HCM, it should be like the gray one. So the HCM one should be thickened, and on the follow-up is also thickened. The left atrial size should be similar to last time, should be enlarged, should be over the normal limits. But this type of the disease like TMT, it can decrease. So TMT usually it will be found in young cats, and they usually have a history of a stress event like general anesthesia. So typically it's like they go neutering and there's nothing happen. They recover eventually, but within like 3 days or 5 days, they present with congestive heart failure. So why they become congestive heart failure? So they think it might be possible myocarditis. So there is the myocardium become inflamed and become edema. So looks thickened, but it's not really hypertrophy. It's just inflammation make it become myocardial edema and looks thickened. So after the congestive heart failure resolved and the inflammation gone, the ventricular wall thickness can be decreased and back to normal. So with this type of disease, the prognosis is quite good. They don't need lifelong medications. Usually when the HCN, when the cardiomyopathy cats, they become heart failure, they usually need lifelong medications. But with TMT cats, they don't need. So this is an explanation you can tell the owner before the general anesthesia. So sometimes there is a risk of TMT, which is unpredictable. We cannot predict it, but there's a risk. And if it looks, if you present like this, before initial echo is thickened, but later it becomes normal, you can suspect TMT if it's a young cat and has some event of general anesthesia. And another report, they think maybe the TMT is sometimes related to the Bartonella infection. Yeah, so TMT is a new thing you may keep in mind if you are doing echo and diagnosing HCN for cats. Okay. So after these diagnosis, maybe you are successful. You diagnose a cat with HCN, and now you want to treat them. So what about treatment? So HCN progression is like this. So it's initially it's a normal heart, and when it got HCN, it can be early stage, it can be subclinical, and later it become clinical and heart failure, and at the end they died. So in different stage, our treatment target is different. So in the subclinical stage, we want to delay the heart failure, but in heart failure stage, we want to control the clinical signs. So we need some evidence to prove the medication can do these things. In subclinical stage, we want a medication can really delay the heart failure. In heart failure stage, we want the medication can control the clinical signs. So this is the ACVN consensus guideline published 4 months ago this year, and they build up a new classification system that we should know to renew our knowledge of the HCN. Actually, any cardiomyopathy, not only HCN. So now the new classification system, they are focused on phenotype rather than genotype. So after you do the echo, you found the heart looks thickened, then you can call it HCM phenotype. So it means the myocardium looks thick. But the reason can including primary HCM, hyperthyroidism, or systemic hypertension, blah, blah, blah. So it's not a diagnosis of primary HCM, it's HCM phenotype. So if you are a client of me in Hong Kong, you will see my report now is writing HCM phenotype, and then we do further investigation to rule out other things. So if we finally found the hypertrophy is secondary to hyperthyroidism, then we call it HCM phenotype in conjunction with hyperthyroidism. And when we after we rule out all the other cause, we can write down that it is really primary HCM. So you have to rule out other causes. So this graph is from the guideline. You can see the HCM phenotype is including lots of things, including primary HCM, including hypertension, reduced preload is which is pseudohypertrophy, and neoplastic infiltration, TMT, acromegaly, and hyperthyroidism. So after you rule out all these things, then you can call it primary HCM. And before this, in cats, there is no clear staging system, but now they build up a staging system just from modified from the dog. So stage A is the predisposing breed, but no evidence of cardiomyopathy now. No evidence on the echo. So like Maine Coon, Ragdoll, they can be stage A even they are only 1 year old. You can say it's stage A. And stage B is there is evidence of cardiomyopathy. So you found some thickened left ventricular free wall, and there's no clinical signs. You can say it's stage B. And they can further divide it into B1 and B2. B1 is low risk of congestive heart failure or arterial thromboembolism. As we know, many cats develop thromboembolism if their heart is too bad. And for the B2 is higher risk of heart failure and thromboembolism. But not yet, no clinical sign yet. And in stage C, there is clinical signs of congestive heart failure or thromboembolism. It can be now ongoing heart failure, or it can be history of heart failure. Means if the cat has heart failure now, and after the treatment, after you stabilize him, even he doesn't have any pleural effusion anymore, he won't go back to stage B. He will stay in stage C. Okay, and for the stage D, it's heart failure refractory to the standard treatment. Then we call it stage D. Okay. So how do we differentiate B1 and B2? So what is low risk, what is high risk? So here is the factor. So usually B1 is low risk of the heart failure or thromboembolism. So the left atrial size is usually normal or only mild enlargement. But in B2, there will be risk factors like Gallop-Hassan, arrhythmia, or left atrial dysfunction, severe hypertrophy, systolic dysfunction of the left ventricle, or spontaneous echo contrast, which you used to call smoke signs, and regional wall motion abnormalities, or restricted mitral inflow pattern. Okay. So what is the treatment? treatment in stage B1, what would you like to give? So we can do a vote again. What would you like to give? Which medication you want for stage B1? It's multiple choice, so you can choose more than one option. Or you only want to choose one, it's okay. Okay. So, whoa, we got many different answers. Okay, but over 50% of you choose no treatment, and 13% of you choose beta blocker and ACEI. Some of you choose diltiazem, and some of you choose furosemide. Okay, spironolactone then. Okay. If you have any idea of any other drugs I didn't mention, you can type in chat window. So maybe there's other option you want to say. Okay, for B1, we said it's low risk of heart failure, low risk of thromboembolism, and there's no signs now for now. So let's see this table. Okay. Here list all the medications, almost most of them, yeah. But first I want you to see here is that actually most of them are not evident to be beneficial in cats with subclinical cardiomyopathy, subclinical HCM. So the only yes is here is taurine. So if the cat has the taurine deficiency cardiomyopathy like DCM, then you can give taurine. Then it has evidence that it will be very helpful. So some of you choose diltiazem. Diltiazem, maybe you want to control the heart rate and improve the left ventricular relaxation, but there's actually no evidence of diltiazem to help in subclinical stage. So it did not delay the heart failure. And furthermore, the diltiazem is not it's not very convenient. It's usually you have to give TID, so it's quite suffering for the cats and for the owner. So we don't use diltiazem as the first line drugs, and it's not proved to be helpful. And another one is I think many of you may think about beta blocker like atenolol, and it can relieve outflow tract obstruction. It can control the heart rate. So if you have experience with atenolol, you may think some of your cats after taking atenolol, the heart murmur is gone. So you feel very good. You feel you treat it and it's cured. But actually, if we see this study, it's evaluating the treatment with atenolol on 5 years. So they follow up the survival of the cat for 5 years from their preclinical stage. So no symptom, stage B. And they follow up 5 years. And you can see the curve here. So 63 subclinical HCM cats, solid line is atenolol, and the dashed line is without atenolol. So the A is all-cause death, the B is cardiac death, and they are almost overlap. Means no significant difference for 5 years. So atenolol failed to improve 5-year outcome in subclinical HCM cats. So actually, it's not as good as we thought. Okay, so stage B1 is low risk of heart failure and thromboembolism. So if you read the consensus guideline, they will say treatment is generally not recommended at this stage. Yeah, because no evidence of beneficial for the medications, and the cats is suffering from long-term medications if they don't have a big risk to develop heart failure. They don't need it. So no evidence that atenolol can help. Okay, but you may consider, so some cardiologists consider it in severe dynamic left ventricular outflow tract obstruction. So if the SAM is severe, means the left ventricular outflow tract velocity is over 4 meters per second, then they may consider to use. But be careful is that atenolol is an anti-arrhythmic drug, so it can also be arrhythmogenic. You can produce a bradyarrhythmia with atenolol. So better you better ask the owner to monitor heart rate at home to see if you really need to give atenolol. We just said that the SAM is dynamic, is depend on the heart rate. So when the cat came to the hospital, it become very nervous. So the heart rate goes high. Then you will hear the louder murmur. So you will measure the outflow tract obstruction more severe during the echo. But maybe at home, it's completely normal. The heart rate, when it come down, the heart rate is like 120, 140. Then there's no SAM, there's no heart murmur. Then you don't have to treat it. Yeah, so better you ask the owner to monitor heart rate at home. If its heart rate is still high at home, and if there is severe outflow tract obstruction, you may consider atenolol. But again, it doesn't improve the survival. Okay, but how about stage B2? Stage B2 means the atrium is now enlarged, and he got higher risk to develop heart failure and arterial thromboembolism. So what medication you want to give in B2 now is the higher risk. So it's still a multiple choice question, and you can choose any option you want. Okay. Yeah, so now many of you think we should give something. Okay, 44% you give clopidogrel, and there's still 39% give beta blocker, atenolol, and SEI, and some of you start furosemide and piombendin. Okay. So for B2, is the risk become higher. So we now are dealing with the increased risk of the thromboembolism. So usually there is moderate to severe left atrial enlargement. If the atrial enlargement is only mild, the risk is not so high. But if the atrial enlargement become moderate to severe, it will be increased risk of thromboembolism. And if the atrial function is decreased, means low left atrial fractional shortening. It means the atrial systolic function decrease. And if the left atrial appendage velocity decrease, so means the left auricular flow decreased, then the blood is kind of not moving in the atrium, then they are prone to become thrombus. And if there is spontaneous echo contrast, then we think there is increased the risk of the thromboembolism. So we can try to give something to prevent the thromboembolism. So the choice will be clopidogrel and aspirin. So which one is the better? Which one is better? Here's the study called Fat Cat study. It's multi-center, double-blind, randomized study. So they choose 75 cats survive from the thromboembolism ATE, and they give clopidogrel or aspirin to see the recurrence. So the recurrence rate in clopidogrel is 49% compared to aspirin is 75%. So clopidogrel is much better. And in 1 year recurrence, clopidogrel is 36 and aspirin is double, is 64. Sorry. And time to recurrence, clopidogrel is longer than aspirin. So look at this curve. So time to recurrence, clopidogrel is mean 400 days and aspirin is 192. So it's double longer than the aspirin. So clopidogrel wins. So if you want to choose something to prevent thromboembolism, you can give clopidogrel. And some of you try want to give ACEI, so it's based on the RAS inhibition. So maybe we can prevent the water retention. We can decrease the sodium concentration. So maybe helpful to delay the heart failure, right? So that's theoretically we think, yeah. And I also think about it. I also agree about it, but there is a clinical study here. So they evaluate the enalapril, how is the efficacy of the enalapril to delay the heart failure. So now you can see that here's two graphs. So this curve is time to all-cause treatment failure, and this is cardiac-related treatment failure. So you can see the p-value is not so low. It's 0.42 and 0.21 and 0.42. So there's no significant difference from the placebo. Okay, and also there's no significant difference on left atrial diameter and left ventricular thickness. So it's not doing the things we thought. From this study, we can see ACEI is actually maybe not so helpful. And some of you choose spironolactone, and I think it's for the same reason. And maybe there's some antifibrotic reason, antifibrotic effect. Maybe he can decrease myocardial fibrosis. But another study shown in this is the spironolactone in Mancune. Okay, they found the spironolactone didn't improve the cardiac-related index in subclinical SCM cats. So actually, almost no drugs are proved to be good. Only clopidogrel is very effective. And you can give clopidogrel only, or if you think there is very high risk of the thromboembolism. For example, you already see a big thrombus in the left atrium. Maybe you can combine with aspirin, or even combine with low molecular weight heparin. And we just seen there is no evidence of ACEI or spironolactone can help. And there's no studies of pimobendan use in subclinical SCM. So some of you want to try pimobendan, but currently no study doing that. And in the guideline, they don't recommend to use pimobendan in subclinical stage. And for me, it's the same. And but you should avoid stress while you re-examine the cats. Like you will need to follow up the cats like every several months, but you should avoid stress, avoid them to become congestive heart failure in front of you. So you can use some pheromone like Feline to calm them down, or you can use gabapentin 1 to 2 hours before they come to visit. So you can peel the cat. You can ask the owner to peel the cat at home when the cat is completely calm. Then when they come to visit you, they will be much better, much less stressful. Okay. So we just talked about the subclinical stage. So what is in the clinical stage means heart failure, congestive heart failure. So what about if your heart looks like this? Looks like so big. So treatment in stage C means congestive heart failure. What would you give in this stage? Oh, some of you choose furosemide in the subclinical stage, but in the subclinical stage there is no need of furosemide, so we don't use it in subclinical stage. Okay, so in stage C, most of you choose furosemide and clopidogrel, okay, and benalopril, pimobendan, spironolactone, also beta blocker. Okay, hello, diltiazem. Okay. So I think no doubt furosemide and clopidogrel are the standard therapy for stage C. And for congestive heart failure, because there is already effusion and pulmonary edema, so you must give furosemide. There's no doubt. And but how about other drugs? So there's no big study here, but this one is done by Philip Fast. It's not yet done. Actually, the study is not finished, but he present on the ACVIN 2003. He collected 118 heart failure cats, so they all received furosemide because they have to get rid of the pulmonary edema. So furosemide is the standard therapy, and for other drugs they divide to 4 groups. So placebo is only furosemide alone. Second group is atenolol plus furosemide, or diltiazem plus furosemide, or enalapril plus furosemide. So the curve is like this. Okay, so this one is furosemide. If you give furosemide only, then the median survival time is 235 days. And if you give enalapril, it's 920 days. If you give atenolol, it's much shorter, it's 72 days. If you give diltiazem, this Dilacor is diltiazem, is 227 days. But this is not yet finished. The study is not yet finished. This is only the preliminary result. But we can see the trend. The p-value is not low enough, so there's actually no significant difference. But you can see enalapril seems maybe beneficial because it goes to like 900 days compared to 200 days. Atenolol may be worse. If you give atenolol, it decreases and only 72 days survival. So you give atenolol may be worse. So we actually we don't give atenolol in heart failure cats. And for pimobendan, so many of the vets want to try pimobendan in cats. It's beneficial for cats with systolic dysfunction, it's no doubt because it can increase the contractility, but it's contraindicated in HOCM. So if you have SAM, if the cat have a SAM with severe obstruction, then there is a risk of systemic hypotension because pumendin can dilate the artery, but there's an obstruction, so the cardiac output is not go out very smoothly, then it can produce systemic hypotension. So we don't use it in obstruction cats. And for the effect of pumendin in 2014, there's a retrospective case control study. So it's not a double-blind study, but it's retrospective case control study. They shown for standard heart failure therapy, mean survival is 103 days. If you add pumendin, the mean survival comes to 600. So looks like pumendin significantly improve the survival time. So pumendin can be tried, but this study, the level of the evidence is not so good. So we are still trying. So it's not a gold standard treatment. You can try. And I will keep pumendin until later stage. So I use furosemide, clopidogrel, and benaropil first. And if the cat is not well controlled, I add pumendin later. So I don't give it at the first timing. So furosemide, you can start at 1 to 2 mg per kilo BID, and we try to reduce the respiratory rate until 30 per minute. And clopidogrel, usually we have 75 milligram tab, so you give 1/4 to the cat SID, and it's bitter, so you have to give it with food, or you can put it in the capsule, then it will be better peeled. And if you want to use pumendin, we only use if he does not have significant obstruction, then we give the dose like this. Or you can give a dose similar to the dogs. So what if stage D, if all things are failed? So you can switch the furosemide to torsemide. So if your furosemide dose comes to over 6 mg per kilo per day, then you may switch to torsemide, which is 10 times potent compared to the furosemide. You can start at 0.1 to 0.2 milligram per kilo SID, and you can add spironolactone 1 to 2 mg per kg SID or BID. Okay. So lastly, I want to recap. So heart murmur is not reliable in cats. So it would be better you can use Gallup or arrhythmia to predict cardiomyopathies. And cardiomegaly is not always present on radiograph, even with congestive heart failure. And so remember, normal left atrial size does not rule out heart failure. And remember to use correct settings and proper algorithm to take your X-ray, and avoid to take an entire cat X-ray. And normal NT-proBNP does not rule out mild cardiomyopathy. So if you got the normal result, you don't tell the owner he doesn't have cardiac disease. It can still have mild cardiomyopathy. And they can be false positive, can be hyperthyroidism, can be renal insufficiency, can be systemic hypertension. So you have to rule out everything. And echocardiography is still necessary. Okay, so if you are doing echo, you have to interpret very carefully and be aware of false tendon or focal hypertrophy. You may miss or you may you may be cheated. And I think feline echo is much challenging compared to the canine echo. So you have to find someone really experienced and to do for you before you can start to scan. Most of the medication are not yet proved to be helpful in subclinical stage. So atenolol may not be so helpful as you thought, and it may be harmful in heart failure stage. So I think for such antiarrhythmic drugs like atenolol or diltiazem, you should avoid to use it if you are not familiar with it. Okay, so we just use standard treatment, which are evident to be beneficial. Okay, so that's it. Thank you for your attention, and I hope you enjoyed my talk today. I would be happy to answer any of question. And thanks again to Mindray to arrange this online course. And I hope you have learned something from this talk. Okay, so now the host is going to collect some question for me. Okay, so one question is that does Dr. Voto cause right ventricular hypertrophy? It's not. It does not cause right ventricular hypertrophy because it's dynamic. So it's not a fixed obstruction. It's dynamic, and it only happens in high heart rate in tachycardia. So if the cat is very calm and the heart rate is slow, then there's no Dr. Voto. So it won't cause long-term high pressure. So it won't cause right ventricular hypertrophy. Okay. And okay, the second question. To what extent does non-cardiac factors of renal insufficiency, hyperthyroidism, and hypertension affect the NT-proBNP level, respectively? I think there is no answer for it. I think you just need to rule out them. But there's some articles that like stage 3 renal insufficiency will significantly affect the BNP level. But I think even it's not stage 3, you still should pay attention, still should rule out other cause of the positive result. And because echocardiography is still the gold standard. So if you are available, if echocardiography is available in your hospital, you can refer to cardiologist. Then you do echocardiography to confirm the diagnosis. So proBNP, I think, is most accurate when the cat is respiratory distress. It will be most helpful. And for the subclinical stage, I will recommend you to refer to someone for echocardiography. Okay. What medication do you recommend to sedate the patient during echocardiography examination? So for example, the gabapentin, if you can ask the owner to peel in at home, I think it will be the best. So before the cat get nervous, you sedate it, then the effect will be the best. And if you need to sedate it in the hospital, you can use acetaminophen for aggressive cat. For the cats not so aggressive, you can try butorphanol first, and if not, you can if it's not responded to it, you can add midazolam plus butorphanol, and for aggressive cat, acetaminophen. Yeah, but I think the best one is if the owner can kill the cat at home, then you give gabapentin at home. Okay, what drug do you recommend? Oh, okay. What drug do you recommend to use control arrhythmia prior to echo? Actually, for arrhythmia, you have to perform the standard ECG study to investigate which arrhythmia it is. So, like ventricular tachycardia and supraventricular tachycardia, the medication is different. And for atrial fibrillation, the medication is even different. So there is no single answer for you to use only one drug to control all of the arrhythmia. You have to first diagnose it. You have to perform ECG to diagnose which arrhythmia it is. Okay. Are cats with history of TMT likely to recur if another stressful event occurs? There's no article talking about the recurrence, but I think theoretically it can be possible because it might be related to myocarditis. So I think theoretically it might be possible. Personally, I don't have any. I have experience of TNT, but I don't have experience of recurrence. So I think this is a new phenomenon we just published in recent years. So we don't have much experience now. So hopefully there will be more article to describe TNT later. Okay. If TNT is true inflammation, so we treat with anti-inflammatory antibiotics. Also, if there is true edema, can we actually appreciate a low echo? Sorry. The question is, if TNT is true inflammation, should we treat it with anti-inflammatory drugs or antibiotics? So actually, we don't have a single drug for myocarditis. So you can try maybe like steroid. You can try short-term prednisolone. But the point is, at the meantime, you don't know it's TMT. So the cat presented for pulmonedema, pleural effusion, and you put a probe on the chest, you see the echo is thickened left ventricle. So you will think it's HCM. So you won't treat it as myocarditis. So you will find out it is TMT later, maybe 3 months later, but at the time you don't need treatment. So usually we don't treat with prednisolone because we don't know at the time. And there's a question: if TNT is true edema, can we actually appreciate a lower echogenicity of myocardium? The answer is not. They look exactly the same with the hypertrophy heart. Yeah, so you cannot differentiate from echocardiogram. You can only differentiate from history. Okay. And okay, what about heparin vs clopidogrel? Clopidogrel is the mechanism of clopidogrel is inhibiting the platelet, and heparin is in fact inhibiting the coagulation factor. So they are different stage of the homeostasis. So there, it's not a VS, it's not heparin VS clopidogrel. There are different mechanisms. So we still use clopidogrel if the risk is very high, like for example, if the cat already had one episode of stomach poison, and he survived, he recovered, then I will give it clopidogrel plus heparin. So actually low molecular heparin, like deltaparin. The name is Clexane. So clopidogrel plus Clexane for long-term control. Yeah. So heparin won't be the replacement of clopidogrel. Okay. And is ECG significant in diagnosis of HCM cats, or for that matter, cardiomyopathy? Yeah, I was trying to put the ECG content into the talk, but it's too long. ECG is not so useful to detect left atrial enlargement. The sensitivity is very low, and for HCM, there is one kind of arrhythmia commonly present with HCM. It's called left anterior fascicular block, LAFB. So this kind of arrhythmia is commonly present with HCM, but not always. So they can be independently. But if you have HCM cat, very commonly you see they also have LAFB. It looks like a reversed QRS on the lead 2, but if you look at 6th lead, it's not right deviation of the mean electrical axis. It's rather it's actually left deviation of the mean electrical axis. So this might be some clue. If I have a cat, I found it have left anterior fascicular block, I may recommend him to do echocardiogram, but it's not a diagnosis of HCM. Yeah, they can be independently. Okay. So other arrhythmia, like for example, if you have HCM because it's hypertrophy of the left ventricle, so they can have VPC, ventricular premature complex. So commonly they have ventricular complex as well. And if the cat have a very big atrium, they can have atrial fibrillation. So these may be some hint for you to do further investigation with echocardiogram, but it's not a diagnostic. You still need echo to convert it. Okay. And another question is, can you explain how to identify cardiogenic pulmonary edema in X-ray? So for the cats, it's quite difficult. And let me find other slides. So for dogs, the cardiogenic pulmonary edema is usually start from the caudodorsal lobe and start from the hilar region. But cats don't read the textbook, so they don't follow the textbook. their pulmonary edema can be very variable in cats. So you can see they are not always start from the caudal-dorsal lobe. So maybe this one is more like canine pulmonary edema in dogs. But for this one, they can be focally here, or they can be cranial ventral, or they can be diffuse. Yeah, so it's kind of challenging to diagnose. So you can try to get some hints, like if the heart is big, it's more likely, and if the left auricle is enlarged, it will be more likely pulmonary edema. And you will see the lung is like interstitial to alveolar pattern. So you may see air bronchogram, you may see lobar sign, and you can take a look of the lung vessels. So sometimes the pulmonary vein will dilate, sometimes pulmonary artery dilate, sometimes both of them dilate. So here are some hints you can try to get a diagnosis, but in cats, they can be none of them present. So the heart can be normal and the vessel can be normal. So you in this situation, you have to have to do echo, I think, or you can refer your X-ray to radiologist, see if they can diagnose for you. Okay. And I think there are some other questions. I just see a question of omega 3 and Q10. I think there is no study to prove it's really beneficial for omega 3 was mentioned in dogs to be beneficial, but in cats there is not really an evidence. But I think it's if in stage B1, and like we said, generally we don't need treatment, and if the owner is really worried about it and they really want to try, and I think it's not harmful to give some supplements. But I won't say it's a standard therapy. I would say you can try if you want. Yeah. Yeah. So supplement, I don't think it's I don't think it's curable. I don't think it's a drug. So I just asked the owner to try. So the only supplement will be beneficial, evident to be beneficial, is taurine. So if the cat is taurine efficiency, you can give taurine, then the systolic function will magically disappear, become a normal heart. Okay. Yeah. So when to administer calcium channel blocker or beta blocker? For me, it's only for antiarrhythmic, and so I will perform ECG before I prescribe such drugs. And as I said, if you want to try atenolol in subclinical stage, you can. It's only used for severe left ventricular outflow tract obstruction. And if in heart failure stage, I think it's according to the slide we just saw it. I don't give atenolol in congestive heart failure cats. Okay, another question is, would you say cat with history of open mouth breathing always has a risk of underlying cardiac disease and should be suggested to perform echo? With open mouth breathing, you have two groups of cats. One group of maybe it's respiratory disease like feline asthma or chronic bronchitis. So other group is cardiomyopathy in cats. So I think first you can take an X-ray to rule out respiratory disease. So maybe you took X-ray, then you found, wow, it's neoplasia. Then you don't need the echo. And if there is a severe bronchial pattern, then you think, oh, maybe it's asthma. Then maybe you don't need echo. Or if the cat also present coughing, coughing in cats is mainly bronchial disease. So if the cat's the chief complaint is coughing, then you may treat bronchial disease first. But sometimes they can have both. They can have both bronchial disease plus cardiac disease. So you can treat the respiratory disease first and see how it's going, and then you decide if you need echo or not. And yeah, and I think if the echo is affordable, is not it's always good to do echo to rule out cardiac disease because they are so silent. And personally, I have some experience in the cat, especially kitten, in cats before under 1 year old. They usually play play very hard, and they are very excited, and the owner will say, oh, after playing they become open mouth breathing, and they came to me for echo, and after echo I found nothing. There's no cardiomyopathy, there's no congenital shunt. So for these cats, maybe more likely respiratory disease, or maybe they just too young, they just play too hard. So sometimes for these cases, after 1 year old, they become completely normal. Yeah. So there's no wrong if you want to do an echo, if it's affordable. How often would you schedule an echo after starting diltiazem? Personally, I don't use diltiazem, but for repeat echo, like for B1 stage, I would recommend 6 to 12 months. So maybe half year or 1 year. I think sometimes the owner might delay the schedule. So I would say six months. I recommend you to come back 6 months, and if they delay, maybe it's not so bad. I won't recommend 1 year and they delay to 2 years and the cat become heart failure. So I would tell them a little bit shorter. So stage B1 I would recommend 6 months, and stage B2 I would recommend 3 months. And if after 3 months is no change, is still stable, then I go longer, like half a year. Okay. And do you use TDI to detect a cold HCN? Tissue Doppler tissue Doppler imaging is good to detect diastolic dysfunction, but the main thing is you still have to measure the thickness of the septum and the free wall. If, for example, if you have a TDI, if you have tissue Doppler abnormal, but the thickness looks normal, you still cannot say it's HCM. It can be it can be other cardiomyopathy, or it can be technical problem. So like tissue Doppler, there's many settings of tissue Doppler. They can be, and yeah, they can be false positive. They can be false abnormal. Different view, different angles, it gives you a different number. So I don't trust only one technique, one measurement. I would recommend you to see the whole picture and to combine all of the results and to diagnose. Yeah, and if everything is normal, only TDI is abnormal, I won't do. I don't want to overdiagnose it, so I won't do anything. I will just monitor. Okay. Would you evaluate diastolic function? Yeah, yes. So diastolic function is good to evaluate in cats, in HCM cats, but I think we should practice more on the things we said before. So first you do a good views, and you measure the thickness correctly, and you interpret other things correctly. Then you do a diastolic function evaluation, because those things, diastolic function those measurements can fool you very much, and you don't have any drugs to directly improve the diastolic function, and there, for diastolic function, grade 1, grade 2, grade 3, grade 4, for the progression, they actually related to the left atrial pressure. So sometimes it's not, sometimes not really the diastolic function getting worse, is actually the left atrial volume, left atrial pressure getting worse. So you have to interpret, you have to see the whole picture. Yeah. So, but it's good to evaluate diastolic function. And which parameter? So for diastolic function, you measure transmitral EA, transmitral flow E and A wave, and you can measure pulmonary vein velocity. You can measure tissue Doppler, and for recent years, there's still there's speckle checking technique for the new machine, but this is under research. This is not yet to be useful, but that might be useful in future. Yeah, so transmitral E and A wave, pulmonary veins, and IVRT in interventricular relaxation time. Also isovolumic relaxation time, and TDI. Okay. And if a cat present with aortic thromboembolism, would medical management just be clopidogrel? Okay, yeah. The question is, if a cat present with the aortic thromboembolism, would medical management just be clopidogrel, or are there any other medications? If it's ongoing thromboembolism, I will give clopidogrel plus low molecular heparin, low molecular weight heparin, so deltaparin, like Clexane. I will give aggressively, like TID, and plus clopidogrel. And if you are more aggressive, you may combine with aspirin, but I haven't go that aggressive, so I use deltaparin plus clopidogrel. And some of the supplements may also be helpful. So yeah, you can try some cardiac supplements. I forgot the name of the supplement. Some enzymes. Yeah. And for thromboembolism, the main thing is they are very, very pain. So they're very painful. So you have to give some analgesics, buprenorphine or other opioid agents. and some of them may need fluid therapy. Some of them may also suffering from congestive heart failure. So you may also treat congestive heart failure. Yes, and maybe keep them warm because they are usually hypothermia. Yes, and there's an old drug called warfarin. Warfarin was also used by some specialists, but it's a little bit dangerous, so I don't use it. And for the fibrinolytic agents like TPA or streptokinase, there is there's study showing they are not so helpful. They can produce reperfusion injury, so the survival is not better than clopidogrel. So I don't use TPA or I don't use streptokinase. Okay, and okay, so I think that's it. And if you have any other questions, welcome you to contact Mindray company, and I'm happy to answer your question after this course. And thank you again for joining our webinar, and I hope you enjoy this talk, and I hope I provide some more information to renew your knowledge. And so now is the time for the host.
Thank you very much, Dr. Eason Yeh, for your excellent presentation and clear explanations. Ladies and gentlemen, thank you for joining us today. Our next webinar will be July the 16th, just 30 days from now. Prof. Pascal's Metz will bring us the fourth lecture, Basic Cardiac Ultrasound, and how to perform it in sport and in practice. Want to know more? Come and join us. Thank you, Dr. Eason Yeh. Thank you all. See you then. Bye.